Good afternoon, everyone. We'll get started. Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just before we begin, just a reminder to please enter your questions in the chat at the end of the presentation. As well, please answer a brief survey that will be sent to you immediately after the presentation. It will let us know that you are present here today. And finally, our visiting speaker today is courtesy of the Division of Geriatrics, and I would like to invite Dr. José Moret from Geriatrics to please introduce our speaker. Thank you.
Thanks, Dr. Giannetti. Hi, everyone. It's my pleasure to introduce you our guest speaker, Dr. Dallas Seitz, who is the chief of the Division of Geriatric Psychiatry at the Center for Addiction and Mental Health, a well-known CAMH, where he also holds the Peter and Shelagh Godsoe Chair in the Late Life Mental Health Research. He's also a professor in the Department of Psychiatry at the Temerty Faculty of Medicine at the University of Toronto and the director of the Division of Geriatric Psychiatry. Dr. Seitz research examines health service and knowledge translation in geriatric mental health. He is actively involved in the development of health system strategies, guidelines, and policies related to seniors and mental health at both the provincial and national level. His research has been supported by Alzheimer Society of Canada, Alzheimer's Association, Brain Canada, CIHR, PIAC, name it. So he's actively involved in provincial and national committees related to seniors' mental health. And today's title of his presentation is Behavioral and Psychological Symptoms of Dementia, Understand Best Practices and Current Quality of Care. Dr. Seitz.
Thank you, Dr. Moret, for the invitation and the warm welcome. And also, I have to say, I've had the opportunity to collaborate with many geriatricians and geriatric psychiatrists here at McGill, Howard Bergman, Isabel Vidal, Claire Goddard, among others. So it's great to be here. And also in geriatric psychiatry and geriatric medicine, we often work closer together than within our, mental health and medicine specialties. We often share clinics. I think we have similar philosophies, so it's always nice to be able to share speaking and knowledge. So I'm going to provide a bit of an overview of some guidelines we recently developed related to BPSD care. Talk a bit about what we know about quality of care compared to these best practices, which I'll tell you is we don't really know a lot. There's a few areas where we have some ideas of quality, and share a few resources that can help clinicians managing BPSD in practice settings, which I hope will be helpful. I've just learning more about the McGill Dementia Education Center and all the resources there, which I think will, complement some of the resources I'm going to be speaking about from some of the work we've done in Toronto. And here are my disclosures, mainly research grant support. I did receive an honorarium for participating in the guideline development. So BPSD, or what I'm going to refer to as BPSD, are really these non-cognitive symptoms associated with dementia. We often think of dementia as memory problems, although the behavior changes are really part and parcel of dementia, and sometimes are some of the more challenging issues that we run into in acute care and other settings. There's a number of different terms used to describe these behaviors. Some places don't like the term BPSD. We use it very deliberately in our guidelines after consultation, but we're also talking about symptoms that are sometimes called responsive behaviors, reactive behaviors, changed behaviors, or neuropsychiatric symptoms. And these are really the broad sort of behavioral and psychological changes that accompany dementia. And most people with dementia will develop behavioral changes at some point. This is some information from a community setting where people tend to have more mild dementia, but even early on or early stages of dementia, these behavior changes are quite common. And early on in the disease course, we tend to see a lot of changes like depression, anxiety, or apathy, or decreased motivation, which can look a lot like depression. But we also see things like sleep changes, irritability, agitation, even early on. And in long-term care, where people with more advanced dementia typically reside, we tend to see even greater prevalence of some of the more challenging behaviors like agitation or aggression, which can make it very challenging for people to provide person-centered care for them. Other symptoms like psychosis, which can be more challenging as well. And most people in long-term care settings have an underlying dementia. I think this number is probably closer to about 70% now in Ontario. I suspect it's fairly similar in Quebec as well. And dementia, most dementias are progressive. They lead to increasing disability over time. And so we also see within individuals, the pattern of symptoms can change over time where, again, early on, people might present more with depression or anxiety symptoms even before they have clear difficulties on neuropsychological testing. But as the disease progresses, we tend to see more challenging behaviors like aggression or disruptions in sleep, which can be difficult to manage. In acute care, dementia is quite common. I'm sure any general internal medicine or surgery. I did my PhD on looking at the relationship between hip fractures and dementia, where about 30% of people who have hip fractures have an underlying dementia. But approximately 25% of general hospital inpatients have underlying dementia. So it's very, very common for your general sort of medical inpatient. People with dementia are about 50% more likely to be hospitalized compared to age-matched individuals without dementia. Dementia is often undetected when people come into hospital, so that's not uncommon. People come in with a pneumonia, their diabetes poorly managed, and then it's sort of uncovered that actually they've been struggling at home with cognitive difficulties that haven't been detected. And this is an area we're doing some research on now, looking at ALC or alternative level of care, people waiting for nursing home or other care settings in acute care. And about half those people, half of all bed days for ALC in Canada are people with dementia, often waiting for nursing homes. I think it's something like 10 million bed days a year, and over $1 billion in expenses. So this has a big impact on ALC and acute care. We also know that when people with dementia are in acute care settings, they're also more likely to have harm during their stay, or potentially preventable complications, things like falls, development of pneumonias, pressure sores, medication errors, than people who don't have dementia. So they're vulnerable to our hospital environment. And I would say similarly, we see challenges, in the emergency rooms as well. And of course, people with dementia will exhibit behaviors when they're in hospital. Sometimes they come in because of behaviors or have behaviors when they arrive, but sometimes the environment and being medically unwell and sometimes superimposed delirium can contribute to the development of behaviors in hospital too. And I'm sure anyone who works on an inpatient unit or consults to an inpatient unit sees, challenges with behavior changes for people with dementia in hospitals. And BPSD is important for several reasons. We know it tends to be a marker of more aggressive progression of dementia. So it's independently associated with functional decline and an increased risk of mortality. It's the major contributor to caregiver stress and placement in long-term care. It's one of the major drivers for decreased quality of life for people with dementia. In hospitals, there's a greater use of restraints for people with dementia of behavior changes. So up to 20% of people with dementia will be restrained, physically restrained at some point during their hospital stay, which we know, talking to Dr. Murray about mobility and just person-centered care, all the challenges that come with that. And we also see frequently people who are on no psychotropics when they come into hospital are discharged often on multiple psychotropics, which have been started to try and manage behaviors in acute care. So I was fortunate to be part of guidelines looking at best practices for assessing behaviors and psychological symptoms of dementia in for people with dementia. This wasn't focused on acute care. It was meant to apply across settings, but I would say most of our evidence that we have is really from long-term care. That's where most of the research has been generated. But I think many of the principles apply across settings, and we'll talk about some of the interventions that seem to be helpful for behavior changes. This was funded through the Public Health Agency of Canada through a grant to our program of the Canadian Academy of Geriatric Psychiatry, which is similar to the Canadian Geriatric Society, but for geriatric psychiatry. And in terms of our guideline development, we followed best practices sort of in guideline development. We had a panel with expertise in BPSD, including a lot of geriatricians. We had one colleague from University of Montreal, Dr. Marie-Andre Bruneau. We also had external reviewers, including people with lived experience and caregivers. And we did an extensive literature review, first reviewing existing dementia guidelines to see what evidence was there. And there were no guidelines that were focused on BPSD, but a lot of dementia guidelines that maybe had a few recommendations on BPSD that we reviewed and published. And then looking at the primary evidence for BPSD, we found almost 300 systematic reviews on different aspects of BPSD, things like, education and training, music, medications. So we didn't do a lot of primary reviews. There was such an extensive body of literature on that had already been synthesized. And then there were a few areas where we did some focused reviews. And to just mention our panel here. So we had an extensive panel with neurology, geriatrics, family medicine, nursing, psychology from across the country. Dr. Jennifer Watt, who's a geriatrician at St. Michael's in Toronto, was a co-chair with me. I was in Calgary at the time that this guideline was started, with a number of trainees and important feedback from people with lived experience on our panel. Most of our recommendations, we followed a 80% threshold for panel members being in agreement with statements to be considered sort of like consensus on a recommendation. The vast majority of them were actually unanimous, where the entire panel did agree with the recommendations, with very few exceptions to that. So to start with, we came up with some general principles for BPSD management. So these are like good practice recommendations, things that are sometimes referred to as like obvious things, but important to emphasize as like a foundation for care. And the first one was more of a policy recommendation around providing education and resources to implement interdisciplinary approaches for assessing and managing BPSD. And I think this is really the foundation for good care for people with dementia in long-term care. And I think also the foundation for, improving behavior supports in acute care settings, as well as really starting with educational approaches and team-based approach for managing this. We also emphasize the importance of informed consent because this is a population that may be incapable at times, but not always. And it's important that their substitute decision makers be incorporated. We also think about goals of care and expressed wishes, and I'll also be thinking about end-of-life care. So the management of these behaviors could be very different for someone who might be sort of in terminal stages of dementia versus someone very early on. And so we have to sort of, incorporate the person's, their goals of care, the family's goals of care in our treatment discussions. And the importance of understanding the underlying dementia. So our guideline recommendations are really focused on Alzheimer's disease and related forms of dementia. Some of the general principles apply across dementias, but some of the specific recommendations, particularly around medications, may be very different for managing things like dementia and Parkinson's disease or dementia with Lewy bodies, where the evidence and risks of medications are very different than Alzheimer's. And then we want to encourage sort of a comprehensive formulation of understanding what might be contributing to BPSD, starting with what we call biological contributors, so good general medical and psychiatric history. This is just like a good comprehensive geriatric assessment, hearing and vision, medication review, substances, pain, sensory impairment, whether there might be a delirium, all these things that can be contributing to BPSD or making it worse. The importance of understanding the person, their background, their values, culture. We were talking about the importance of language and how that can make all the difference in communicating with someone who doesn't, for everyone, but particularly for people who might have some cognitive impairment. And also thinking about how interpersonal interactions and the physical environment might be contributing to behaviors. So I think when we think about our acute care environment, and this is not to, criticize, but, it's busy, it can be loud, it can be a bit chaotic. And sometimes that, we find it overstimulating and kind of stressful for people working in the environment. And if there's ways to make that a little less stimulating and chaotic for people who have cognitive impairment, it certainly helps, along with how we approach our communication. We also encourage thinking about using person-centered language, so not labeling people their symptoms, like they're a wanderer or things like that. That's not helpful to use that type of language. The importance of psychosocial interventions and tailoring psychosocial interventions that are most likely to be effective for each individual. So that involves kind of understanding your patient, like their background, their interests, language, and all of that, but also understanding their abilities. And I think this is a little bit challenging to kind of figure out. You want people to be engaged in things that are meaningful for them, but that sort of meet up with their functioning level. And so sometimes we have to adjust communication or activities to kind of meet where the person is at or adapt that over time. And then to routinely assess the management plan and consider adjusting, changing, or discontinuing strategies that may no longer be needed or which aren't effective, including medications. So in addition to the general principles, our guidelines then went through a process of identifying which behaviors or types of behaviors we wanted to focus in on, because BPSD is such a broad topic, includes things like sleep, depression, agitation, which can all have different causes and different treatments for them. And so the topics that we initially prioritized in our guideline were agitation, which is like repetitive vocal or movements that are not just an attempt for the person to have their needs met, and which are causing distress for the individual. So that's the key thing, is not just like being a little bit restless or kind of rummaging around. It's really looking at behaviors that are posing some degree of risk or distress for the patient or those around them. And we also looked at depression, anxiety, and then sexual changes in sexual behaviors, or sometimes referred to as sexually inappropriate behaviors. And then the last topic, which wasn't sort of like a BPSD syndrome, but which was important, was deprescribing of medications. which are sometimes started to treat BPSD. So that was our last topic. So there was a few key areas that, so our guideline project was 18 months in total, which isn't a lot of time to develop a guideline on a pretty broad topic. So there were some areas that we had to leave out, two of which were really important were sleep and apathy. And so we were fortunate actually to get funded through CIHR to develop sleep and apathy guidelines, which we're just starting that work. And Jennifer Watt from the University of Toronto is the PI on that grant. So looking forward to sharing that in the future. So in terms of agitation, so again, this repetitive vocal behavior, sometimes it can, in severe forms, can take the form of aggression, where there's, physical or verbal aggression towards others. When we reviewed the literature, by far the strongest evidence was interdisciplinary approaches to care that involved educating the care team on BPSD, like basic things like triggers, assessment skills, care planning for BPSD, structured approaches to assessment, incorporation of individualized care plans and meaningful activities for the person based on that assessment. So that by far has the best evidence. And there is a little bit of evidence for this in acute care as well, that if you have an interdisciplinary team, often focused on education with nursing staff or frontline staff, that incorporates these principles, that it actually helps reduce behaviors and also decrease staff stress. Aside from these multi-component interventions, things like animal-assisted therapy, like pet therapy, which can be a challenge in hospitals or others, but maybe you have a pet visiting program here. Some hospitals do. Robotic pets, physical exercise, even simple exercise or seated exercise can help with this. Having access to preferred music, and also things like massage or aromatherapy. Aromatherapy is very difficult to implement because of scent policies and sensitivities and things like that. But some of these things are probably things that could be implemented, often with the help of your interdisciplinary staff and family members in acute care settings as well. In terms of pharmacological treatment for agitation, a number of medications that were recommended in our guidelines. So citalopram is an antidepressant with some evidence for agitation. It's one of the drawbacks of it. It tends to be well tolerated, although it can cause falls and cognitive impairment, like a lot of psychotropics in older adults. It takes a while for it to take effect. And so, if you need to be looking at sort of a 4 to 8 week treatment trial, which, for someone who's acutely agitated in acute care is not going to be like an effective sort of treatment in that situation. For severe agitation, there's evidence for some atypical antipsychotics. So we've listed 3 here: aripiprazole, brexpiprazole, risperidone. They're all relatively similar in terms of adverse effects and effectiveness. They can take effect, relatively soon after starting, within a few days. Important to start low and go up gradually. You have to be careful about which ones you select in certain people because of propensity to cause Parkinsonism and things like that. But these are reasonable options. And then for people who've maybe failed or not tolerated those treatments, we provided some other recommendations, including other antipsychotics like quetiapine or typical antipsychotics, and then sort of lower down in more treatment refractory cases where you probably are going to be working with your geriatric psychiatry colleagues or on specialized behavioral units, things like synthetic cannabinoids or anticonvulsants. There's a bit of evidence. We also provided some recommendations around emergency treatment of acute agitation, and for that we recommended low dose antipsychotics, so like low dose haloperidol. This is for like an emergency or code white sort of situation. Or if someone can't have antipsychotics, a low dose of a benzodiazepine like lorazepam. Again, just for absolute emergency situations on a short-term basis, and that's just to ensure like safety and often to initiate an evaluation of what's caused the behavioral emergency. And then there's a whole bunch of things that we recommend against. So starting cognitive enhancers, that doesn't tend to improve behaviors in people who have severe behaviors. Other antipsychotics like olanzapine, which is sometimes used, we recommend against because of side effects and it's not effective. Other antidepressants, other than citalopram, there's some evidence that some of these are not helpful. Things like sertraline, which we often use sertraline in older adults because it has low risk of drug-drug interactions, but probably not a good treatment for agitation because it's actually dopaminergic, and so you don't. That tends to agitate people as opposed to citalopram. And other medications like trazodone and mirtazapine, which are frequently used sometimes for sleep or behavior changes. There's no evidence really that these are effective for agitation in Alzheimer's disease and can cause side effects. And then other general principles like don't use long-acting antipsychotics, which sometimes get started. Someone gets a depot of an antipsychotic as their first trial, or polypharmacy. We also recommend against the use of seclusion and restraint. Maybe it sounds obvious, but it needs to be stated. A lot of harms associated with that. It's not person-centered. And then also some guidelines around recommended durations of treatment. Just also going to touch on the depressive symptoms as another area that we looked at in our guidelines. I won't go through all of them. But you see some similar principles for things that are effective for agitation, also help with depression, and also help with psychosis and anxiety. So again, these interdisciplinary approaches to dementia care, understanding the person, contributors to their symptoms, providing people with cognitively stimulating activities, so enjoyable activities that sort of engage their abilities, reminiscence, which is really sort of engaging in the person in terms of their background and past history. So sometimes knowing a little bit about this person was a teacher, who loved horseback riding or whatever, that just having that little bit of information so you can make a personal connection sometimes makes all the difference for someone who has cognitive impairment. Occupational therapy approaches to sort of help people with dementia compensate for the difficulties they're experiencing because of their dementia. This is more in a home-based setting, can be helpful for depression because it helps people, to be more engaged and feel more meaning in their life. And then some of the other things like exercise and things like animal-assisted therapy or robotic pets can also be helpful for depressive symptoms. And for medications for depression, we discourage against using antidepressants for people who have mild depressive symptoms, that don't meet criteria for a major depressive disorder. And then for people who do have depression, that is like a major depression, with the 2 weeks of symptoms accompanied by, sleep changes and appetite and negative cognitions, that we recommend medications that are generally recommended for treatment of depression in seniors, which are certain serotonin reuptake inhibitors or medications like duloxetine. And then a final area to talk about is around a deprescribing of medications for BPSD. So often people will get started on these medications and then just left on them, or sometimes they're started on these medications for maybe not the right indication to begin with. So our guidelines recommended considering deprescribing antipsychotics in people who shouldn't have been on it to begin with. So we often see, people who are started on antipsychotic, after a trip to the Emerge, when they were delirious, they no longer need to be on it. Or maybe they were started on it because, they were wandering around at home, and we know that these medications don't work for that. So, that's a good reason to stop it. For people who needed to be on the medications because they had severe symptoms or they had an indication, you have to think about how long they've been treated, how severe their symptoms were, the dose of medication that was required to stabilize them, to sort of guide who you might try to deprescribe and who you may want to leave on the medication because they're unlikely to come off it without a recurrence of of symptoms. So there are some ways to kind of predict who will come off of antipsychotics. Of course, if you have a condition like bipolar disorder, treatment refractory depression, or schizophrenia, you should stay on the antipsychotic. You know, that's different than dementia. And sometimes you see people where there's like some deprescribing that's happening a little bit off target because it's not dementia related. It's more of a serious mental illness. And then like other deprescribing recommendations for things like benzodiazepines or other medications, is recommended to gradually reduce it over several weeks and monitor for recurrence of symptoms. And sometimes you can't get the medication completely stopped, but even a graduated dose reduction can be helpful in terms of preventing adverse effects. We also recommended reviewing other medications aside from antipsychotics. So I think like the bigger issue now, there is still a lot of attention on antipsychotics, but it's close to 70% of people in nursing homes are on antidepressants, often multiple antidepressants without good evidence, and benzodiazepines are still used quite frequently as well. So we want to encourage people to think about other medications beside antipsychotics that they might be on. And then there are ways, again, in team-based approaches to help with deprescribing, often involving sort of your geriatric specialist, family physicians, pharmacists, and the care team to sort of come up with structured plans to review medications, particularly in long-term care. So just to talk a little bit about measuring quality of BPSD care. So it's great we've got these guidelines. And we know some areas where there's potential quality issues, but really, unless we're sort of measuring quality or thinking about it, it's hard to make improvements. And I would say this is an area where we're like really early, very early on compared to some of the work we see in areas like stroke and cancer, where, you know, access and quality of care is measured and reported publicly pretty regularly. We don't really have as great of information on BPSD care. These quality standards here from Health Quality Ontario outline like the key things that organizations should be thinking about when it comes to BPSD care. So they're meant to apply for long-term care and acute care, and sort of touch on a number of the different areas that I talked about in our guidelines. But in terms of you know, an organization maybe wanting to do some quality improvement work related to care of people with dementia, this might be a good place to kind of start to look at areas where you might be able to sort of start to make some improvements around, you know, standardized assessments or care plans, or even thinking about order sets or considerations around things like medications as some examples. So I like these as just sort of, and these quality standards tend to be aspirational, right? They kind of want you to stretch and think towards the future, but this is probably a good starting place to think about quality in hospitals. What we do know about quality related to BPSD is around prescribing. And one of the things that's actually been pretty concerning, the middle slide here, is inappropriate use of antipsychotics. And so this is like before COVID, and now this is more recent data, 2023 to 2024. We actually are seeing pretty much across the country, there's a worsening, like there's an increased use of antipsychotics in long-term care, which is concerning because there was a lot of attention sort of in the mid like 2015 to 2020 to try and get people to reduce the use of antipsychotics. I think COVID happened. We kind of took our eye off the target, and now we're starting to see things kind of drift up, which is concerning. And aside from antipsychotics, this is the rates of antidepressant use in long-term care, and I think this is one of the maybe the unintended consequences of some of the attention on antipsychotics is we started deprescribing antipsychotics and starting things like, you know, antidepressants in their place, which in some cases, you know, may be safer but ineffective and not needed as well. And maybe a good news story about use of benzodiazepines is that we do see that, across most age groups, the use of benzodiazepines is going down, but the highest use group is still seniors. So this is, if you're age 75 and older, you're about like 3-4 times more likely to be on a benzodiazepine than someone in their 20s, which is like the exact opposite of when you think about like the risks and side effects and the evidence, where you would sort of want to be seeing that trend. We're using probably the most hazardous medications in the most vulnerable patient populations. And some of our other measures that CAMH reports in long-term care around behaviors, which are incomplete, and these are not like a comprehensive measure of quality, as shown again, the antipsychotics has probably worsened. The rest of the quality indicators really haven't moved that much, which I think probably just reflects that we're not actually paying attention to them to the same extent, and even the ones that we were really focused on seems to be getting worse. Hopefully some policy recommendations that have come out more recently from the Canadian Drug Agency are to sort of level set a little bit around antipsychotic use in dementia. And so before, as we were trying to reduce antipsychotics as an area of quality, we didn't really have a target, right? It was just like go lower. And so we were often looking at, what were the targets that were used in the United States for this, where they were able to get down their measures of antipsychotics to about 13% with sort of a federal approach to antipsychotic reduction in Medicare funded homes. But recently, the Canadian Drug Agency has set a hard target saying that we want all homes to get down to 15% of inappropriate antipsychotic use. So that's about close to half of where it is now. They think that that's achievable with current resources, just with attention, and awareness to it. And they don't expect homes to get there overnight. And so if you're above the target, it may be a several-year process to get there, but are trying to set some benchmarks, for homes to work towards. So I think that this benchmarking of actually setting targets and measuring and reporting across homes with these targets will hopefully help this area of quality for BPSD. The other thing I would say in long-term care and probably acute care as well that really affects quality of care and behaviors is staffing, and this is a big concern in long-term care. I'm sure it is in acute care too, of just being understaffed or under resourced. And this is particularly concerning in long-term care where there's, I think in COVID, a lot of people who were care aides, LPNs, registered nurses left long-term care. It was extremely stressful. It was stressful to begin with. COVID made it extremely stressful. And we're seeing that for most health professionals, there's less and less people going into long-term care. And we did an analysis looking at just in the US, all the 10,000 nursing homes in the US. If you looked at antipsychotic use and staffing levels, we saw for homes that were funded similarly but staffed more consistently, that the greater the staffing hours, the lower the rate of antipsychotic use. And so I think some of this does come back to policy implications around like appropriate staffing levels to be able to achieve some of these targets. The biggest change was with registered staff. So the more registered staff you had, that seemed to be a bigger predictor of lower rates of antipsychotic use rather than just increasing healthcare aide or personal support worker hours. And another policy recommendation that recently came out, which has some good recommendations, it's for long-term care, but also has some good recommendations, I think, for considerations in acute care around general principles for caring for people with mental health, including dementia, are the Canadian Standards Association. So we probably think of the Canadian Standards Association of like, people who put the stickers on our bicycle helmets and like hockey gear and things like that. But they also do workplace standards for mental health and psychological safety and standards for the care of people in healthcare environments. And so they actually published some standards on like what are the staffing, training, systems considerations that are essential for providing good quality care in long-term care. And again, they're not sort of enforced standards, but they're aspirational. And I already hear long-term care associations in Ontario and other places saying, we look at these standards as what we want to be delivering. We want to be like in compliance with these standards. We want to be delivering best care for our residents. And so hopefully this will help support that as well. I'm going to spend just my last few minutes here just to talk about some resources that I find like helpful just as kind of like tools and things that people can use to start thinking about incorporating into their practice. So one framework I like around this, which is I think easy to sort of communicate in terms of like understanding BPSD, is called the DICE approach. And this really kind of gets at like understanding things in the environment with the person and with the people around them that might be contributing to behaviors. And the DICE stands for sort of just starting with a describing of the behaviors, going through an assessment. This is good, like comprehensive geriatric assessment, investigating contributors to this. And this is where your colleagues from geriatric medicine can be very helpful, or geriatric psychiatry, or your advanced practice clinical nurses and educators to investigate causes, and also the person's background to create a plan to try and address those things and then evaluate that over time. So I really like this kind of simple conceptualization. It just forces people to kind of reflect and go through things in a little bit of a structured approach to understand behaviors, because it can be pretty complex to assess. And again, thinking about, are there things in the environment with or the patient or the people interacting with the person with dementia that are contributing to this? So this is kind of the trinity of contributors to BPSD, and it's rare that there aren't factors in at least one of these areas that we might be able to shift pretty easy. Often there's factors in all three that are actually not that hard to address if we pay attention to them. I like this caregiver communication tool from Baycrest. It sounds like the McGill program here is developing similar ones where it's really both as healthcare providers and as family members to have a calm approach. And so if we approach interactions with people with dementia in a calm fashion, that is less likely to aggravate behaviors, and sometimes all that's needed to de-escalate things. So they use the acronym CARE. I heard someone else say ABCs, if you think airway, breathing, circulation, right, in an emergency, but it's always be cool or always be calm. So if you're in a behavioral emergency, ABC, always be cool. You go in cool, it's more likely that the person you're interacting with is going to be cool or de-escalate as well. Dr. Murray was talking about sort of a cookbook of interventions or strategies that caregivers can use with people with dementia. This guide here, put out by Behavioral Supports in Ontario, I think it's only in English. It was actually designed for acute care. And so it's meant to be sort of a simple guide that staff can use in terms of how would you implement something like music or a conversation. And so it's free to download. It's really excellent. And then they have a whole bunch of adaptation tips, like if someone has sensory impairment or mobility problems, how would you adjust the approach? And they've probably got about 40 or 50 activities. You can kind of like scroll through exercise or art or conversation starters. And I think it's a really great, tool that a family member could use, but it was actually designed for acute care to help people with some practical tips. There's also some prescribing resources. So this one incorporates our guidelines. It was actually produced by the Center for Effective Practice, which is a sort of a primary care continuing education group. So it's free to download. And all the medications in our guideline are kind of in there in a algorithmic approach, along with like details around dosing, side effects, drug interactions. So I find that to be like a good sort of user-friendly guide to our algorithms. Along with, there's some really good deprescribing algorithms, both from deprescribing.org and then some patient resources at Deprescribing Network that you can use to sort of initiate conversations about antipsychotics or other medications. And the last thing just wanted to briefly touch on is, and we were talking at supper, like starting to think about also like a kind of a systems approach to behavior care for people with dementia, including the work I think that's happening here at the McGill Education Center around at the foundation, building capacity and knowledge with our caregivers and frontline staff. But then looking at how do we also collaborate with, our mental health and geriatric medicine teams, to provide support and consultation to acute care, thinking about things like specialized nursing home settings to help people with more complex behaviors. And then at the tip of the iceberg, we do need inpatient beds, specialty inpatient beds for the most complex behaviors, for people in our healthcare system, but sort of thinking about an integrated care approach. And we certainly don't have it figured out in Ontario, but we do have some provincial bodies who are coordinating behavioral support for people with dementia, where they've tried to identify and develop the pathways for people in the community, people in long-term care, but also people in acute care. So how do we sort of leverage the resources that are available and think about bringing together all that expertise to support the entire system, because people with dementia move throughout the system. And my last slide, I just want to briefly talk about the CCNA, which Howard Churkow is the lead investigator on. He's now at Baycrest, but of course, continues to have strong ties here. We were fortunate in the latest round of the CCNA to have a team funded to look at health system performance for dementia, really looking at measuring and reporting quality of dementia care across provinces in Canada. So we're very excited to be starting on this work. It's initially going to start for people with dementia in community settings, but two of the areas that we're going to look at in the future phases of this would be long-term care and also acute care, trying to understand some of the quality issues and sort of catalyze improvements in dementia care across settings. So just to wrap up, hopefully you've shared some of the best practices in BPSD care, which involve largely psychosocial, but some pharmacological approaches that are tailored to individual needs. I think the little bit of information we have is that there are opportunities to improve quality of care, including better measurement of care, and that includes acute care. And I've shared some resources, but I think we need resources, that education, and sort of system planning to really think about ways to improve BPSD care at the population level. We have a great website with some resources for clinicians and caregivers at the behaviorsanddementia.ca. So you can go there and download a lot of resources there. We have a number of seniors' mental health resources also available on substance misuse, delirium, depression, available at CCS, social isolation and loneliness, which we know is also a lethal problem affecting society. And then all the other things I referenced here will be in my reference list. These are all great evidence-based resources for dementia care, improving dementia care, supporting people with dementia. So thank you. So we have a few minutes for questions.
Thank you so much for this wonderful comprehensive review on such an important topic. There seems to be quite a few questions in the chat. I'm just looking here at the first question about the use of aripiprazole used in agitation compared to risperidone, given its very long half-life. Any comments on that?
Yeah, so it's a good question. So aripiprazole does have a long half-life, but actually in trials and network meta-analyses, even with its long half-life, it tends to have a lower adverse event profile than risperidone, and maybe a lower adverse event profile than brexpiprazole. So I think, I would say it has probably comparable or maybe slightly less likely to cause adverse events. It can still cause adverse events. It's not that it's not without safety issues, but I would say there's nothing to suggest that it's worse from a safety perspective, might be a little bit better. The one challenge with aripiprazole with its long half-life is it can take a while for it to start, and it doesn't work well as an as needed or PRN. And so sometimes as you're titrating the dose up, you need to also maybe look at a shorter acting medication like low dose lorazepam while you're kind of getting the dose of aripiprazole up. So that it can be a little bit more challenging to titrate if you're not familiar with it.
Magdi, I see you have your hand up. Do you want to mute 30 seconds? You're muted, Magdi.
Yeah, hi. Can you hear me now?
Yes, yes.
Yeah.
Yeah, okay. So first of all, I want to congratulate you. It's a very good presentation and fantastic work of dealing with those guidelines. The thing I find a bit disconcerting, if you like, is that there's very few words, if any at all, on the
Sorry, Magdi, we didn't hear that last part.
I heard the first part, which is you love the guidelines.
Yes, okay.
You say
Thank you.
Do you want to just type into the chat? There's a lot of questions,
Yeah.
and we'll come back to you. Wendy?
in the
Oh,
yeah, okay.
yeah. Magdi, please enter your question in the chat.
Yeah.
I'm going to move on to Wendy. Could you comment on these BPSD recommendations are extrapolated to management of agitation and other delirium?
Yeah, I think so. It's a great question. I think, truthfully, the principles are pretty similar where, the psychosocial approaches, the communication strategies, we have much more evidence, I think, in delirium about things like environmental orientation, hydration, like a good hospital elder life kind of programs, that help with the delirium. I think the evidence for medications in delirium is probably, even though I would say it's kind of guarded in BPSD, the role of like antipsychotics in management of delirium, I think, is both the prevention and acute treatment of delirium shows that like they're not effective, in reducing delirium severity or delirium outcomes. So, and then things like antidepressants, would not be appropriate for managing agitation in the context of delirium. So I think that, again, the pharmacological approach is probably the not psychosocial approaches would be very similar to what we might try for agitation, which you might also recommend in delirium.
Okay. Okay, so Magdi gave me his question. I think it's a bit similar to the question that Sasha has there. Can you tell us about over-the-counter supplements that we see more and more used by people, melatonin, ginkgo biloba, and Magdi wants to know about food supplements, these kind of things.
Great. Yeah, so I would say there's not much evidence for most supplements for either cognitive or behavioral symptoms in dementia. The sleep guidelines will definitely look at melatonin. I would say it's a little mixed as to whether melatonin has some benefits for sleep in the context of insomnia in Alzheimer's disease, maybe a bit of evidence for REM sleep disorder in conditions like dementia with Lewy bodies. One, I would say, over-the-counter, the thing I see a lot is cannabinoids. I see a lot of seniors who use CBD or sometimes THC, and sometimes it's a son or grandson who, I'm having trouble sleeping, or mom seems restless or agitated, and they try those kind of things. Again, not a lot of evidence. There's some evidence for agitation for things like nabilone, which is synthetic THC. There was a large study of dronabinol, which isn't available here, but somewhat similar to nabilone that might be helpful for agitation. There's a study going on of cannabidiol for agitation. So an area we need more evidence. But I generally, with my patients who are taking these things, I'd say in general, they're harmless other than a waste of money, and not much evidence that they're effective for dementia.
Can you tell us about anti-TNF or any kind of Janus kinase inhibitors for dementia?
No, that's totally out of my wheelhouse. I'll have to look that up. Although there was a trial of semaglutide that was just published this past week, which was negative for Alzheimer's, for people with, I think, established MCI or Alzheimer's disease. Yeah.
Sorry. Yes. Go ahead. Lauren.
I noticed you're comparing a lot of our quality data to American Medicare funded LTC. My brief time working in the States suggests to me that when you apply public funding to quality indicators in the States, people find creative ways to make the quality indicator.
Yeah.
Whereas in Canada, we seem to be a little more honest about our reporting. No. Have you compared us to other countries outside of North America? How do we do against them?
Yeah, so I think with the US, because we're both on the minimum data set, most of our long-term care use a similar reporting framework. I don't think Quebec uses MDS in long-term care, so it's a sort of like a inter-RI standardized assessment, which allows a little bit of benchmarking across countries. So, in some areas, like prescribing, I think we are worse in North America than what we would see in Europe, where I think they're just isn't the same culture prescribing for behaviors, and also perhaps a little bit more attention towards like person-centered environments and things like that. Not that everywhere in Europe is like that, but I think you see more sort of thoughtful design around that. So often that's why we are like looking at the US data, because we have similar data sources and probably a little bit more similar to them in terms of culture and practice. But yeah, but we need more data. Basically, the only thing we report on publicly is antipsychotic use, and people do game the indicator. They take people off antipsychotics and load them up with trazodone. They attach a diagnosis of schizophrenia where there wasn't one before, because that doesn't get counted in the indicator. They refuse to take people on antipsychotics or are reluctant because it's going to throw off their indicator. So, we have to kind of keep our eye on those like balancing measures or gaming, which we do see in the US and in Canada.
Dallas, I like your opinion on education of healthcare professionals, because these are complex diseases, conditions, and the level of tolerance of our healthcare professionals is very limited, and they expect someone already has cognitive difficulties before even the BPSD occurs, and we expect them to act normally. So we have to educate our healthcare professionals to accept a certain degree of flexibility in what they are observing, and
Yeah, and not just people with dementia. I would say, so we at CAMH, we have an initiative called TIDES, which is it's trauma-informed de-escalation. So it's like they developed it at CAMH, which is a big 500+ bed mental health hospital. Like, how do you approach someone who's in a behavioral crisis in a conversation that tries to de-escalate the situation? And then like acute care said, well, we need that on our surgical units, and we need that. We have the same thing. People wind up in crisis because of pain or just the way whatever's going on, and a similar sort of approach. So they're doing training for acute care and now moving into long-term care as well. Just those basic communication and de-escalation strategies, because if you start off on the wrong foot, then it's really hard to course correct, even for someone who doesn't have dementia. It makes it all the more challenging when you do.
Thank you.
Any final pressing questions, Mark?
Sorry, I might have missed it during your presentation, but these benchmarks, like the 15% in long-term care for antipsychotic use, why not 5%? Why not 30%? Where do they come from?
Yeah, so I was part of that panel. The thing with the indicators is they're imperfect, and so they're always going to. So, like as an example, that indicator does not take into account whether you have agitation. So they say if you have schizophrenia or your palliative care, Huntington's disease, you can be on as much antipsychotics as you want, and we're going to say it's appropriate. Everyone else, and if you have psychotic symptoms, it's appropriate. But the most common reason we use them is agitation. And so agitation is not part of, you could be agitated and violent, put on an antipsychotic appropriately. The indicator is going to flag you as inappropriate. And so that 15% is a little bit of the kind of the fudge factor. Why not revamp the indicator to incorporate agitation? That's a good question. I don't know why they haven't done that, but it takes into account that 0 is probably under treatment for a typical population of people with dementia, and 30 is probably too high in a typical environment. So they want to kind of look at, and there's also part of the variation is like you can see there's similar homes. One home will have 15% with the same group of patients and resources, another will be 30. And so it's like, well, if this home can do it, we think other homes should probably at least be able to get to, people in the top quartile as a benchmark. Yeah.
We are out of time. It's 1 o'clock. I will ask Sasha and Marie and Nicola if they want to stay on, so maybe you can answer the final questions, but we will have to close out the session. Thank you so much. Really a terrific and obviously generated a lot of questions and discussion. So thank you so much for this wonderful presentation. Thanks everyone for attending.